Copyright Stanford University, all rights reserved.
So I think we're going to get started. I guess we couldn't find a speaker, so I'm the substitute speaker for today. So, so just to go over some announcements. Next week, we have Bonnie Gersh. He's a professor in Mayo. He's really a legend in our cardiology field. He's going to talk about the challenging epidemiology of AFib and stroke. And then he'll also stay overnight for the Department of Medicine Grand Rounds. And then for this week's Med 223, we have Mohan, who's going to talk about stem cell therapy for arrhythmias. And just keep in mind that the talks right now are being recorded, and it's going to be on YouTube, so including this talk as well. For the CVI Faculty Club, for the next week, we have, this week, we have Wei Zhao, professor of vascular surgery at the Palo Alto VA. She's going to talk about the effects of carotid disease. And just for the 2014 retreat, it's going to be on December 2nd. Again, make sure you register for the meeting. For the postdocs and graduate students, there will be a cash prize awards for the best abstracts that Ingrid will fill in later. And then for the travel and CVI travel awards, the deadline is coming up on November 10th. Manuscript award, the deadline is January 15th. And then again, if you have any questions on this, please talk to Ingrid. So I'm going to talk about what we've been working on for the past couple of years. And again, I'm talking because we couldn't find a speaker, so I'm substituting for our speaker. And so how do I switch, David, on this? So you can see this. Okay, so so I'm going to talk about how we've been doing cardiac iPS cells for disease modeling, drug discovery, and also some regenerative medicine applications. And so this is my disclosure slide. We have a partnership with several companies, as well as co-founded a small company, startup company. So I think this slide needs no introduction in terms of the prevalence of cardiovascular disease. It's actually the #1 cause of morbidity and mortality for both men and women, much higher than the other diseases listed here, including cancer, accidents, chronic lower respiratory disease, and diabetes. And I came to Stanford in 2004, and at that time we started working, trying to figure out how do you take human ES cells to differentiate the cardiomyocytes. Just keep in mind that prior to that, 6 years ago, Jamie Thompson's group discovered isolation of the inner cell mass from a human ES cell. And from these cells, they're characterized by self-renewal as well as pluripotency. It means that they can differentiate into pretty much all cell types. And because I'm a cardiologist, I was trying to figure out how do you do the cardiac differentiation. And I would say it was difficult at that time because of the limited FDA-approved lines, the ethical concerns associated with the human ESL research, and also the difficulty with the funding because back then it was during the Bush era. And so in 2006, 2007, Shina Yamanaka discovered that you could take a skin or blood or any somatic cells and reprogram them into iPS cells. And so this changes, in my opinion, the paradigm of how we do stem cell research. And this is also part of the reason why in 6 years he received the Nobel Prize in Physiology of Medicine. So just imagine having the ability to take skin and blood from everybody in this room, make your iPS cells, make your cardiomyocytes, and then do disease modeling, do drug testing, and also do transplantation. So I put down transplantation is back in 2004, when we were first working on this, we were really interested in transplantation because we didn't really think about how do you make iPS cells or how do you take cardiomyocytes from a diverse population of patients. So now with the iPS cells, it opens up these two areas as well. In terms of the cardiac differentiation protocol, I won't go over all the protocols out there. Suffice to say, over the past 10 years, there has been significant improvement of the cardiac differentiation protocols. So that different protocols are out there, and I think started with 3D switch monolayer, and right now it's a lot of the protocols, in my opinion, are much better with the monolayer and chemically defined. So back in 2004, as you can see, these are the cardiomyocytes right here. This is non-beating cardiomyocytes. This is what the cardiologists would call junk cells. Junk means that you can have bone, hair, or other cells that we're not interested. These are the cells that we're really interested. You can see something twitch. So in 2014, you can clearly see that the efficiency has improved dramatically in terms of making these cardiomyocytes. And instead of using human ear cells, we routinely take blood and isolate the PBMC, make iPS cells, and then differentiate them to cardiomyocytes. You can actually see it without the microscope. So this is a 6-well slide in which you can see the cardiomyocytes right here squeezing here. And so once you have cardiomyocytes, the other thing that we try to do is try to make it so that we can make a lot of these cardiomyocytes at a very low cost. So just to give you an example, if you were to buy a T-cell bottle or EA bottle from Life Technology, probably costs you on the order of about $150 to $250, depending on how many bottles you order at a time. And because we're making cardiomyocytes at such a high volume, we had to get the cost down. The other thing is that with commercially available bottles, there's quite a bit of lot-to-lot variability depending on the FBS, the fetal bovine serum. So this is a study that probably took us about 3 years. It's done by Paul Burridge, instructor in our lab, in which we basically define what's needed to grow the cardiomyocytes, and we call it chemically defined generation of human cardiomyocytes. Essentially, it consists of a basal media, L-ascorbic acid, and human recombinant albumin. And to make a bottle of this media, it probably would cost you somewhere between $40 to $50. So we get a significant price advantage from this method here. So once you have these cardiomyocytes that you can reproduce, and you can also crank out at a very high efficiency and a very low cost. It's a matter of trying to figure out what is it that you're interested in studying right here. So this is a cardiomyocyte right here. It's got the nucleus, and within the nucleus, there are several diseases it can go after. Likewise, within the sarcomere, likewise within the channels. And so shown here are different diseases that people have studied using iPS cells as a model. So I'm going to focus on a couple of these diseases that we've been working on for the past 2 to 3 years. This is a familial hypertrophic cardiomyopathy, most prevalent inherited cardiovascular disease, one of the most common causes of sudden cardiac death in young adults. Back in 1989, the first gene identified as mutation in myosin heavy chain 7. Since then, more than 500 mutations identified across 27 genes. Initially, a lot of this similar work was done by Christine and Jonathan Simon's group. So shown here is an echocardiogram of somebody who has hypertrophic cardiomyopathy. So we were lucky enough to recruit a large cohort of patients from UNASLE's Ashley's clinic, in which the mother has a disease, and she had 8 kids, and the kids 1, 2, 3, and 7 have the mutation. The mutation is a myosin heavy chain 7 with the arginine to histidine switch. And kids 1 and 2 already had the phenotype shown by the black box right here. And the phenotype is on the MRI sagittal cut. You can see the thick septum there. So the question is, making iPS cells from all of this entire family, differentiate the cardiomyocytes, generate enough clones to get reproducibility. And what we found out probably about 2 to 3 years ago was something that struck us by surprise. That is, if you were to look at the cardiomyocytes from the normal healthy sibling versus the cardiomyocytes in the patients with hypertrophic mutation, the cardiomyocytes is already bigger. You can see the cell size right here compared to the normal siblings. The cardiomyocytes also have more multinucleation. You can aggravate the hypertrophy by giving isopaternal or some kind of catecholamine's stress. There's also increased NFAT pathway, and you can block it with calcineurin inhibitor. So this is really surprising for us because it tells you that the patients, even though they haven't manifested the disease, when you make the iPSC differentiate the cardiomyocyte, they already have the hypertrophy. So it took us a while to understand that concept, but right now, I think several labs have already repeated this data. So it's not a novel concept anymore, but back then, I would say about 4 years ago, it took us a while to kind of digest that information. And the other thing you can do is you can come in with drugs. This is a Verapamil. It's a calcium channel blocker, and you can show that the hypertrophy right here. With the Verapamil, you can shrink the size of the cell. These cells also have more arrhythmias than the control siblings cells. And again, you can come in with the Verapamil to block the arrhythmias by calcium imaging. So that, for example, by day 40, the untreated cells have this amount of irregular calcium transients. And then when you treat it with the Verapamil, you can block this as well. Likewise, these cells have more DADs, or delayed after depolarization, and you can come in with drugs to block this pathway here as well. So now you kind of set up an assay that allows you to see how good your drug is in terms of blocking these pathways. So this has already been published, and the first author is Feng Lian, and he's going to take a faculty job in Anzhen Hospital pretty soon. And so what we think is happening is the myosin heavy chain 7 increases the intracellular calcium, activates the NFAT, activates hypertrophy. The increased intracellular calcium leads to calcium handling defects, leads to arrhythmia. You can exacerbate the arrhythmia by isoproteinol stress. You can exacerbate the hypertrophy by isoproteinol stress. So we demonstrate that in the paper. And you can also block the arrhythmia as well as block the hypertrophy by using beta blockers. You can block the arrhythmias by using lidocaine with mesilotine and venlafaxine. And likewise, you can block the arrhythmias by using Verapamil. So this is one platform. I'll quickly highlight, because it's also been published, the result of another big study that we did. Took us a while. This is a 3-generation family, also recruited from UN's clinic, in which the grandmother has a disease, 2 kids, and grandson also has a disease. And the disease is a troponin T mutation with the arginine to tryptophan switch. And just like the previous work, you take the skin, make the iPSC, differentiate the cardiomyocytes over a span of about 3 years, try to figure out what the mechanism of the disease is, and try to come in with common drugs, such as metoprolol, or actually gene therapy. Circa-2A is already in clinical trial. This is a trial done by Roger Hajar's group at Mount Sinai in the QUBIT trial using AAV virus with Circa-2A in patients with heart failure. And this work was done by Ning Sun, who's a professor at Fudan University right now. So what I've shown you, a couple examples of what I would say genetic, low-hanging fruit, acquired cardiomyopathy diseases. You will see in the next 5 years or so, or the next 10 years, more and more people will start going after acquired diseases and also multifactorial diseases, acquired diseases, for example, myocarditis, peripartum cardiomyopathy, diabetic cardiomyopathy, radiation cardiomyopathy, nutritional cardiomyopathy. In the past, it would have been very difficult for you to model these diseases. Now you can get cardiomyocytes from pretty much anybody. You should be able to model some of these diseases using these cardiomyocytes. So let me give you an example. This is a study done by Arun Sharma, who's a PhD graduate student in my lab and also in Sean Wu's lab. And what Arun did was he took a patient and made iPSC, differentiate the cardiomyocytes. And in collaboration with Jan Carrett's lab, we took Kawasaki B virus linked to luciferase. The Kawasaki B virus is one of the most common causes of viral cardiomyopathy. The Kawasaki B hits the cardiomyocyte, and the light color pops up. And so you can detect the quantification of the viral transfection. And so we now set up an assay in which is more color means more transfection, less color means less transfection. And you can come in, again, with antiviral drugs to figure out what drugs work and what drugs don't work, right? So now, if you're a company and you're interested in this particular area, then this would be a perfect platform for you to see what is the effect of Kawasaki B virus against cardiomyocytes. Another example, this study just published this week. This is done by Ming-Xiao Gu, a postdoc in the lab. In this case here, we're going after a statin and how statin can reverse obesity-induced dysfunction of iPS cell-derived endothelial cells. These are not cardiomyocytes. And the gist is that in a mouse model, you can clearly show that the control iPS cell-derived EC upon exposure to some kind of stress, in this case hypoxia, versus the diet-induced obesity endothelial cells, there's more cell death upon exposure to the stress. And when you come in with the statin, you can block the stress as well. And I think Ming-Xiao has elegantly worked out pretty much the mechanism of how statin reverses this phenomenon, reverses inflammation, reverses cell apoptosis, reverses oxidative stress, and a lot of it has to do with the nitric oxide pathway. So I give you an example of how we're trying to use these iPS cells to do drug assays, drug development. And this is really a bulk of my lab for the past 3 years, past 4 years that we've shifted our focus to. And that is, how do you take everybody's skin in this room, make iPS cell, differentiate. This is a review article written by the Pfizer Drug Development Group. Differentiate to all the different cell types here, come in with the drug and see what is the efficacy, what is the safety of your drug, and how do you compare that to different cohorts. As you look across this room here, we are all different people, different race, different sex, different background, and so forth. And what is the effect of the drug on this type of platform? And so this is a area that's quite important to the big pharma. I think some of you may know that it usually takes about $1.8 to $2 billion and 12 years on average to get a drug from the beginning to the end. One of the major reasons for the inefficiency is because the data you get from mouse does not necessarily equal to human, and this is pretty well known. And then the other thing is that this is not clear to a lot of people, is that cardiac toxicity is actually the #1 cause of a drug withdrawal post-marketing. It accounts for about 30 to 35%. Why is that? So think about this. So if I'm a company, drug company, and I give Francois a drug, and he gets a rash, I probably don't care. I just say put some cream on, right? Steroid creams. On the other hand, if I give Francois a drug and next morning he doesn't wake up, I care because I'm going to get sued. And so this is the reason cardiac toxicity is the #1 cause of drug withdrawal post-marketing, followed by liver toxicity. Now, why is it that the traditional testing is unlikely to inform cardiac risk? So put yourself in a pharmaceutical company's shoe. You don't have patients' cardiomyocyte. You can work with neonatal cardiomyocytes, but those are difficult to work. Rat or mouse neonatal cardiomyocytes, when you isolate them, typically they're good for about 45 days and then they all died off. And so you need some kind of assay that's easy for your technicians to work with. And the assay, most robust assay, is actually taking a hamster and ovarian cell. So does the ovarian cell beat or not beat? Ovarian cell does not beat, right? And so they shortcut it by taking ovarian cell and overexpress with the hERG channel. And hERG channel is one channel out of probably 20 to 30 major cardiac channels in the cardiomyocyte. And then you do all the drug screening this way. And so if you have a drug that blocks the hERG channel, the assay is going to be positive, you kill the drug. If you have a drug that blocks this channel right here, it's not even going to be detected by the hERG channel assay. So you go to the next phase until you realize something's wrong, and then you basically go back and kill the drug. And so this is the reason why there has been a lot of issues with this type of drug testing. And so this is a review article that Kareem and Ying in the lab has written up, discussed, submitted to Circ Research, kind of highlight some of the drugs that have been withdrawn due to cardiac toxicity. Shown here are several drugs. Drugs get withdrawn for different reasons: poor arrhythmias, heart attack, QT interval prolongation. I want to focus your attention on the drug called cisapride. The Cisapride was a drug that was withdrawn in 2000. When I was a health staff at UCLA, I probably given out about 500 prescriptions of Cisapride. Good drug. Diabetic patients with gastroparesis like that, we give it to them, help them digest the food much better. So I'm going to go back to Cisapride and try to tell you how we can do a quote-unquote clinical trial in a dish. This work was done by Ping, who's now a professor at Zhejiang University in China. And so what we decided to do is to do 12 patients, 3 control patients, 3 long QT patients, 3 hypertrophic patients, and 3 dilated cardiomyopathy patients. And at baseline, you can already see that the long QT patients have prolonged action potential compared to the control, compared to the hypertrophic, compared to the DCM. And remember, Cisapride was marketed by Johnson & Johnson for diabetic gastroparesis, right? And so if you give a low-dose Cisapride, 1, 3, and 10 nanomolar, actually nothing bad happens. All these patients tolerated the drug okay. If you give high-dose Cisapride, very high dose, 300 nanomolar, pretty much everybody gets arrhythmias, everybody. And so what happens if you give a physiologic dose, somewhere between 30 to 100 nanomolar dose? And this is very interesting to us. It's telling you that the long QT patients, they get into trouble. The hypertrophic patients, they get into trouble. But the control patients and the DCM patients, they're fine. So this begs the question that why is it this drug, given to more than 10 million patients, 400 reported cases of Torsades 80 death? Is it really true that if I give drug to everybody in this room, all of you guys will drop dead? Probably not. And so I think if you have this information during the development phase, what would you do? There's probably 3 possibilities, right? The first possibility is just kill the drug. Don't even bother with it. The second possibility is you market the drug and you have a black box warning in the back says that anybody who's going to take this drug will have EKG checked at least. And the third possibility is you go back to your medicinal chemist and say, work on it so that I don't see this data anymore, right? And so this is an example of how having more information helps you upfront, helps you with the drug design and drug discovery here. I also want to show you something that we've been working on for the past couple of years. It's genome editing of isogenic iPS lines, and I think the main advantage here is that we don't need to recruit a patient anymore. So the advantage here is that we're able to take skin or blood from anybody in this room, and we make iPS cells, and you tell us what is the cardiac disease that you want to study. You may be interested in long QT1. We'll knock in the long QT1 mutation. You may be interested in hypertrophic gene. We'll knock in the hypertrophic gene into the cells. So this whole process takes us about 3 months to do. And so just give you an example. This is a paper published by previous postdoc who's also a professor at Fudan University right now. And so what Yamin did was he took a long QT1 and long QT2 patient. And so you can see that in a control patient, the action potential is fine. Somebody with the long QT1 mutation, you'll see the action potential is prolonged. So you go back to take the same control patient and genome edit to have the same long QT1 mutation, you can see prolonged action potential right now. And so this is going to, in my opinion, this is going to rapidly accelerate our throughput in terms of using drug testing, because if I go back to this list right here, this is a list of some of the mutations that could occur. And in the very beginning of the talk, I gave you examples of myosin heavy chain 7 troponin T, right? And it took, actually, it took my colleagues, you and a while to recruit these patients for us. Think about how long it would take us to recruit all these patients right here. How long, it may take us 10 years because none of the patient with, let's say, Titan mutation ever showed up, right? And so now, instead of recruiting the patient, you can just do the genome editing approach. And so this is something that we have several postdocs in the lab working on. So Ionis and Tor and Timon and you are working with Matt Portier's lab and also Vittorio's lab using this. And this is a library. We started this about 2 years ago. So in the beginning, we picked Talon. Right now, we're gradually switching to CRISPR. So this is a library of different mutations, myosin heavy chain 7, troponin, laminin, so forth right here. It's mutation 1 to mutation 48. You can see mutation 49 to mutation 92, 96. And we're trying to go after 96 different mutations. And essentially, the concept is that you can take my skin, make iPSL, and then you can create 96 different lines of my iPSL that has 96 different mutations. You can then understand what is the effect of mutation A versus mutation B versus mutation C, because the source is always the same. If I take 2 different people there, and one of them has mutation and then the other does not, I cannot completely account for that the difference that I see is due to the mutation. It could be just a different genetic background. So now with the genome editing, it really accelerates the ability to do that. So this is what we're trying to do. This is the Stanford Cardiovascular Bank. We're trying to create a biobank of about 1,000 lines for drug discovery, and using patients with different ethnicity, sex, age, and also using the TADE and the CRISPR editing. We routinely perform DNA-seq as well as RNA-seq on these cell lines and differentiated cardiomyocytes. We work with Russ Altman's group to annotate this on the PharmGK database. And we work with Susan Weber's group to do it on the STRIDE database. And we're also working with the CIRM, the California Institute of Regenerative Medicine, and the NHLBI on this iPSL biobanking, and also with the FDA on drug safety testing. So we have biweekly calls with the FDA staff on this as well. And at the end of the day, what we're trying to do is establish a sharing resource plan so that 10 years from now, 15 years from now, anybody across the country, if they need a line that has myosin mutation, a line that has phospholamban mutation, they could look up a database, and the Stanford Cardiovascular Institute would have these cells, and we'll just ship it to them free of cost. So at the same time, to get there, we're developing some of the technologies for high-throughput drug screening. This work is done by a lot of these talented postdocs and graduate students here. The gist is that we're making a lot of these cardiomyocytes. We're making a lot because we've significantly improved our differentiation. We're making them at a low cost, and we screen them. And actually, we recently got a consign with the Iron Proton and Iron Chef from Life Technology for free. And this allows us to do sequencing on exome sequencing on pretty much all our lines at about $400 per line right now. And then we also do a lot of these assays development as well to do this type of drug therapy and screening. So what I think is going to happen is that you probably in the next decade, you'll see a paradigm shift in terms of how we do drug discovery. In the past, it's from here to here, and sometimes it's costly and slow. And I think in the future, you'll see from here to here to here. The meaning is that it's not going to replace clinical trial, but it's going to give you additional information before you go to clinical trial so that your clinical trial can be more precise, smaller, and more cost efficient. Because you're going to test your safety and efficacy of your drugs on X number of patients beating heart cells from different cardiovascular history, different sex, men and women respond to drugs differently, and also different ethnicity. And the positive results would then be used for the in vitro testing, would then give you more confidence before you go into these larger clinical trials. So I'm going to focus on this one slide right here. This is an area of interest to me. This is a paper that just got published last month by one of my postdocs, Antia, in collaboration with Daria. And you guys probably know this. For some Asians, when they drink alcohol, their face are flush, myself included. So when I drink alcohol, probably this amount of alcohol, my face flush, my heart rate goes up to about 150s, 160s. So I call it exercise for the lazy man. So you don't have to exercise. You drink it, your heart rate goes up. It's also a protective gene because it's, it makes it very difficult for you to become alcoholic, because the feeling of heart rate shooting up, flushing, it's actually very annoying, irritating. So we decided to do this study. We put up an ad and recruited 10 Stanford undergrads. And the ad says we're looking for Stanford undergrads who flush when they drink alcohol. And 10 of them showed up. We made iPSCs from them. 5 of them flush, 5 of them does not flush. We did sequencing to confirm that they actually have the aldehyde dehydrogenase polymorphism. And what's interesting is that the patients, when you make the cardiomyocytes from these 2 cohorts, exposed in the same kind of stress. Could be hypoxia stress, could be chemical stress, could be some kind of stress. The patients who have the alcohol dehydrogenase deficiency, same amount of stress will die much more, the cardiomyocytes. It kind of gives you some confidence to clinical observations. Clinical observations have shown that Asians who have this particular deficiency, when they get a heart attack, they tend to have a worse outcome. And this also points to what I think is that a lot of the drugs out there, you will see differences in terms of men, women. You will see differences in terms of whether they're healthy or have cardiovascular disease. And you will see differences whether they're Asian, Caucasian, Hispanics, and African Americans. And so this is part of the thing that we're trying to create for our iPSC biobank here at Stanford. The last 10 minutes, I'm going to touch upon the regenerative medicine area that we've been working on as well. So this is a review article published in 2013, and it's listing some of the ESL, iPSL-based regenerative medicine that could occur. And look at the prediction right here. So the author here predicted that for the iPSLs, that the clinical trial could begin in mid-2014. And this is using iPSL-derived retinal pigment cell injected into the same patient with macular degeneration right here. And so this is a news press from actually 2 months ago in September here, in which Japan announced the first trial. They took a woman in her 70s who had macular degeneration, made iPSL, differentiated the iPSL retinal pigment cell, and put it back in the same woman. And so this is pretty, I would say, very, very amazing story in terms of how the discovery of iPSL was made in 2006. In 2014, it's in clinical trial. But Dr. Yamanaka can do this because he's almost like a demigod in Japan, and he has a lot of funding. For us, we have to go back to square one. So we've been thinking about this for a while. How do we do ESL, iPSL trials? And so the first question for the iPSLs is, we have to ask a question, if I make iPSL from the skin versus iPSL from the heart cells, is there a difference, right? If the heart cell give you better iPSL, then we probably need to take a biopsy of the patient's heart cell, make iPSL, differentiate the heart cells. So Veronica, who is a former postdoc in the lab, worked on this issue, isolated fibroblasts and cardiac progenitor cells from the heart, made iPSLs, differentiated them, and then studied them in vitro, in vivo. I think the bottom line here is, from what I found, is in the beginning, you'll see a difference, meaning that in the beginning, the early passages, when the cells came from the CPCs, you tend to get more cardiomyocyte. But then as you passage them for a longer period of time, you don't see a significant difference anymore. And likewise, you don't see a significant difference in terms of EP. You don't see a significant difference in terms of their functional outcome. So this is good. This means that if you're thinking about iPSL cardiomyocyte therapy, you can just take it from the patient's skin or blood and make cardiomyocyte and inject back in the same person, rather than having to do a cardiac biopsy at first here. So we've been working on a lot of these issues. We have to be very careful with these studies because one of the questions that we always get asked is tumorigenicity, which means that when you differentiate the iPSL, differentiate the ESL and the cardiomyocyte, what happens if there are residual contaminants of these cells, right? So if I differentiate 100 cells and 100 of them becomes, 95 of them becomes cardiomyocyte and 5 of them are still remaining as undifferentiated cell, if I inject into the patient, do these 5 become a teratoma? And so we've been working on this. This is published in 2006, and that tells you we've been working on it since 2004 in terms of understanding the tumorigenicity. So how do you make sure that there's no undifferentiated cells within the 50 to 200 million cells that you plan to inject into patients? There's no data on long-term follow-up in small and large animal models. We actually think it's low risk, but it needs to be absolutely 0% risk, otherwise the field is doomed. We don't want to be associated with the first cardiac group to be injecting these iPSC ESLs and then see a whopping tumor. That would be not a good publicity here. But I actually think that because of the significant improvement in the cardiac differentiation protocol, I'm actually much less concerned about this issue. Meaning that back in 2004, we were only getting about 5% cardiac differentiations. Right now, we're able to get 95% cardiac differentiation. The other issue that we had to deal with before we go into these cardiac clinical trials is immunogenicity. Remember, for the ESLs, it came from somebody else, right? So it has to be allogeneic transplant. And so we started working on this in 2006, and you can see the paper got published in 2008. In fact, I think for many of the iPSL therapies, it's also going to be allogeneic. And the main reason is, when you think about it, you put yourself into the shoe of a big pharma, a biotech company, and how much return in investment do you get from making my iPSL, differentiate the my cardiomyocytes, and put it back into me? How much can you build from that? You can't build that much, right? And it's a lot of hassle to go through all the steps. It's much better, much easier, much more profitable to take a few standard lines, optimize them, do QC on it, and ship it to everybody who gets a heart attack, right? Somebody who gets a heart attack in Phoenix, you send it to them. Somebody who gets a heart attack in Montana, you send it to them. So that's a much better business model, and this is the reason why I think, at least in the cardiac area, it's going to be allogeneic in the future, and this is the reason why we need to figure this out. In our experience, this is actually a very difficult issue to work with. We started working with this with Rucker, who's a vascular surgeon, and then and then Rucker, when he left, and Jeremy, who's now a anesthesiology resident, and then right now it's being led by Nigel. We're still trying to work this out. I think we have better experience in terms of how to handle this as well. And then the third area is really the preclinical models. For the cardiac therapy, the FDA actually requires two different models, a small animal and a large animal model. And so we've been working on this. You can see this one is 2008. That tells you we've been working on it since 2006. I would say this is probably one of the most challenging aspects because it's very expensive to do large animal studies. So it costs $100 on average. It's actually an underestimate. I just found out recently the exact price. Suffice to say, it'll take you typically about $30,000 to $40,000 to do a pig study that has, in our experience. And so this is difficult to get NIH funding because it's not mechanistic enough. The other thing is that showing efficacy in randomized double-blinded study will require a large patient number. Who's going to pay for this? So who's going to pay for your phase 2, phase 3 randomized trial? Stanford is not going to pay for it, right? So you have to figure out who are your partners, and most of your partners in the end is going to be biotech. And when you talk to biotech, what is the first question they'll ask you? What is my return on investment? Right? And so this is an issue that needs to be addressed, and this is part of the reason why a lot of times this is what we call a valley of death right here. The last thing is, how do you monitor the fate in patients, and what is the competitive advantage of these ESL or iPSC-based therapy versus adult stem cells out there? I need to show the cells are better than the adult stem cells, and for the adult stem cell field, they need to show that the adult stem cell is better than the conventional therapy. Right, so that's pretty tough to do. So we've been working on it, and I listed Ming-Sha, Andrew, and also Tricia, who's an assistant professor with imaging expertise working on these areas. So we have a CIRM cardiac disease team grant, and the gist of the grant is taking a human ESL, differentiated cardiomyocytes, check safety and efficacy in small and large animal models, and then later on put it into LVAD patient. For this grant, I'm assisted heavily by Joe Gold, whom we recruited from Geron, and actually Joe sitting there. We're also being helped. This is really a team effort by Phil Yang and the other Joe Wu, Larry Cooter, and who give us GMP, GLP grade cells, and Deepak right here. And this is a very complicated slide, but to summarize, we are at about year 1.9, year 2 into it. At year 4, we're supposed to get an IND from the FDA. Now, you look at all of this right here, and I wasn't used to this probably about 2 years ago when I look at this. Assay qualification, selection and optimization of assays, provisional specs, product production of pilot-grade materials, stability program, pilot toxicology studies, small, large animal studies, so forth and so forth. This quickly made me realize that probably about 95% of the work that we do in the lab is never going to make it to the clinic because of all these issues right here. 95%, if not more. And so, I'm getting educated each day, working with smarter people than I am, trying to figure out how do you take this from the concept stage to a clinical stage here. In addition to this, I'm also being educated by Wolfram Zimmerman, who's a expert in engineered heart muscles. Wolfram and I have had a very fruitful collaboration over the past 2 years. And you can see what Wolfram has done and what he has taught us is that taking cells matrix, make it together, and what we call this a calamari ring right here. You can see something twitch, and you can put it in a patch right here as well. And so this work is done by Johannes, Evgenios, and Oscar and Alina. And the gist is that when we inject the cells in, a lot of times the cells die. And wouldn't it be better if we put it in the tissue engineered format and put it onto the heart to allow the cells to survive here? And lastly, we have tried to build up, although this is quite rudimentary, stem cell experience. In fact, in the very beginning, we actually have to piggyback on our colleagues in Slovenia. Francois Haddad introduced me to Bohan, who's one of the most energetic interventional cardiologists out there in Europe. And within a span of 2 to 3 years, Bohan has taught us quite a bit of how do you conduct clinical trials. In this case here, it's using CD34 cells in the patients with ischemic versus non-ischemic cardiomyopathy. Francois and I have actually flown out to Slovenia. I had to look at the Google map to see exactly where Slovenia is before I boarded the plane. And so that it kind of puts us into shame that, we need to ramp up our effort here. And a lot of this is, the other thing I would point out is that Stanford is part of the CTSN, and the PI for that is Joe Wu, and the other Joe Wu, and he recently published a trial using mesenchymal precursor cells into LVAD patients. Stanford is also part of the CCTRN trial. The PI for that is Phil Yang, and in this trial here, Stanford is partnering with several other sites to do these type of multi-site clinical trials. And at the same time, we are partnering with several other companies out there. And we've actually added 2 trial coordinators, Ashima and also Ed. And then David is helping us with the cell injection, and Kareem and Trisha is helping in terms of coordinating. And part of the goal is we want to set this up and basically have them run with the program here. So I want to summarize by talk about the cardiac iPS cells, the disease modeling. I give you examples of how we can do this to understand the mechanisms of DCM, HCM, long QT. I think the challenge in the future is trying to model complex, non-monogenic diseases. We have some ideas how to do it. The other area that I focus on is drug discovery and pharmacogenomics, trying to create a biobank of about 1,000 of these lines, which I think will accelerate drug discovery and also improve safety screening as well. And here, the main task is trying to convince the industry and FDA to adopt this as a new platform. We're getting there because, I think the industry and the FDA has come to us for help for a lot of these issues. And then the third area is I give you examples how we're trying to address the issues such as tumorigenicity, immunogenicity, and efficacy in preclinical studies needed to get the IND from the FDA. And here, our main obstacle will be trying to show the competitive advantage of ESL, iPSL-based therapy versus the adult cells. So I want to conclude by giving you the 3 scenarios. This is almost like a CME course, even though it's not a CME. So you're the big pharma, and this is only 5 years from now. So you're the CEO of company X. The high cost of the R&D is killing into your margins, and you're not happy about that. And the clinical trials are costly and show mostly negative data. And you're interested in adopting new assays that will allow you to study, in this case, cardiac focus, cardiac channels. What is the effect of my drug on sodium channel, on potassium channel? Cardiac metabolism. What is the effect of my diabetic drugs on cardiac metabolism? Contractility. What is the effect of my drug on improving the contractile function on patients with cardiac dysfunction, whether it's heart failure with preserved EF or heart failure with low ejection fraction? And also on top of that, how do you make sure my drug is safe enough from a cardiac standpoint? And with these questions, how would you set it up? And I would say that you can probably use the iPSL model to address some of these questions. Now, in 10 years from now, you're the doctor. I see some medical students here in the audience. So you have a husband and a wife who have 4 kids, and 2 of them already had heart transplant at age 16 and age 14. The other 2, age 6 and age 10, are fine. You go do DNA sequencing, and you can't find anything. There's no annotated mutations to explain for this. And then the parents ask you, what's going to happen to my other 2 kids? And right now, the answer is, I don't know. But we'll check serial echoes and MRI on these 2 other kids to see what happens, right? So my proposition to you is that if we're able to show that the husband and wife, for some reason, let's say, for example, the cardiomyocyte beat like this. The age 16 and age 14, when you make the cardiomyocyte from them, they don't beat. Now, the age 10 beat like this. The age 6, when you make the iPSL cardiomyocyte, it doesn't beat at all. Do I have enough confidence to tell the family that I don't know what the mutation is, but I think your age 6, when he gets older, he will develop the disease, right? So this gets into really the concept of personalized diagnostics. It's a very, very dangerous area, but a lot of tests needs to be done to push for that concept here. And then the last scenario is, in 20 years, 15 to 20 years, you're now the patient. You're a 65 patient who got diagnosed with heart attack, MI. You need to be medically treated. What medication should you be taking on? Instead of you being the guinea pig, which happens all the time when you go to a clinic, can the physicians in the future test drugs first on your mini-me surrogates, right? Using your iPSL-derived heart cells, brain cells, liver cells. If I have Parkinson's or Alzheimer's when I'm age 65, I don't want to be taking all these medications. I'm going to tell my doctor to test it on my brain cells first and tell me what medication I need to take. Same concept for the cardiac disease here. So I want to acknowledge, this is a long list of acknowledgement. I acknowledge the postdocs in the lab, the instructors in the lab, the cardiology fellows, the graduate students working in the lab. And I also want to acknowledge Joe Gold, who we recruited again as a safe and Geron to work on our CIRM projects. The biobank team, Changli, Yan, and Mohammed and Rinkal, my very capable 2 lab managers, Justin alone, and 2 trial coordinators to help us recruit patients, 2 in Ashima. My collaborators at Stanford, many of them I've kind of listed their work here, and also my collaborators outside of Stanford. And so this slide here kind of summarizes what we're trying to do with the cardiac iPSL biobank. So right now, we set up a system in which anybody in the country can email us for cardiomyocytes. Very simple MTA, and then after the MTA gets signed, we'll ship them about 5 million beating cardiomyocytes, free of cost except for the shipping costs. This is funded by R24 grant. The other thing is, if it's an interesting family and they need help, they can send us the blood from the family, and we will make the iPSLs, and we will bank it here at Stanford. We'll also give it back to them. And this is part of our effort to create this CBI biobank. And then you can contact me, or you can also contact Justin for this. So we ship this to probably more than, at this moment, 60 different investigators across the country with these iPSL cardiomyocytes. And with that, I want to thank you guys for your attention, and I'll be happy to take any questions. Yeah, thank you very much.